I really mean it. You're as healthy as your endothelium because it is. So the moment you're born, we start accumulating towards atherosclerosis. So we gotta really think about the endothelium. So my name is Nazish Sayed. I'm an assistant professor in the Division of Vascular Surgery, Department of Surgery. I have no disclosures, but the biggest disclosure is that I'm not a surgeon, but I'm within the Division of Vascular Surgery in the Department of Surgery. And I'll try to convince in the next 45 minutes how important it is that a basic and translational scientist can bring towards vascular surgery, as Dr. Lee mentioned, that we do need to kind of mix together the translational aspect, which we can help our surgical colleagues, but also learn from the surgical colleagues that what we can implement back into the lab. A few of the disclosures, as Dr. Lee mentioned, I am funded by the National Institute of Health, American Heart Association, and most importantly, Stanford, who bet on me initially, giving me the startup to do the work which I do. So let me start my work by telling you throughout med school and grad school, one of the things which really fascinated me was the vasculature. And if you have ever got a chance, read the historical concept of when the vasculature was coined. I mean, way back in BC. But the real hard work or real map work, which was done by Dr. Vesalius, is mapping the different vasculatures all the way from the brain to the toe, and actually giving them these Latin words where these vasculatures. This is a 16th century artist and a physician who took on this tremendous work of mapping the vasculature, which has put the groundwork of where we are right now, understanding the importance of the vasculature from providing not only nutrition, oxygenated blood, but also providing different kind of hormonal and endocrine niche to it. So on this groundwork, which really fascinated me towards the vasculature, what happens is when we are looking at the vasculature, you could see that, this is basically the plumbing of the human body. And if you look at this map and then you compare it to your household plumbing, the vasculature is basically doing what the house plumbing does, bring in fresh water, but at the same time taking out the waste materials of the body. And this is what the vasculature does. And that's why it's so fascinating, is that you have oxygenated blood flowing through the body, of course, using the motor of the heart as the pump, pumping this oxygenated blood, but you also have the venous blood or the lymphatic system, which is now removing all the waste materials so that it can be recycled or it could be excreted out of the body. So the vasculature is basically, if you can understand plumbing, as simple as that, you could understand the mechanics of the cardiovascular system, because it is a crucial part of bringing in fresh stuff and removing the waste materials. And it's amazing that how simple as plumbing, we could understand vascular biology and how vascular surgeons are able to remove the dead tissue, provide grafts so that we can keep this circulatory system running. So with that in mind, what happens when this vascular plumbing goes south, goes awry? And what we see is a bunch of many vascular diseases, which we in the vascular division deal with all the time. I'm just going to label a few of them. Our division is absolutely an expert trying to correct aortic aneurysm as well as AAA disease, peripheral artery disease. And as I said, just label a few of these vascular diseases. You have peripheral artery disease. We have been hearing a lot because of COVID exposure. A lot of people coming more with peripheral artery disease. Varicose veins, the division has a very good varicose vein program led by Dr. Fukaya, so on and so forth. Chronic limb ischemia, which usually leads to BK below knee amputation. So this is what happens if our vasculature system decides not to do its function. We're going to end up a bunch of diseases, and I'm not going to name a lot of them. So, and the important thing, it can affect anyone. It can affect of any individuals, young, old, and some of my topic towards the end of the talk, I'm going to bring about aging, which might be interesting to a lot of them, because as we age, our vasculature system, our sewage system is going to age as well. And I'm going to bring in that topic to discuss. So within the division, we see a lot of these vascular patients coming in, but we at Stanford, and especially within the division of the cardiovascular, the CT surgery as well as vascular surgery, we have transformed how to take these patients in and cure them for vascular disease. I'm just showing some historical concept here. Dr. Shumway doing the first heart transplant system within Stanford, and within our division, the strengths, as I mentioned, about AAA disease and aortic aneurysm, of how we are able to surgically repair most of these patients which come in. But today, that's not, as I said, I'm the non-surgeon within the division. This is not, I'm just setting you guys up because I'm presenting in surgical grand rounds. I want to bring in the new concept of what we can do as an alternate explanation for the surgery. Of course, we need surgery for these patients who are going to come in with these many different diseases. That's the immediate cure which we need. But what can we do behind the scenes so that we can actually provide better vascular health, better vascular care for these patients? And what we have been trying to do within the division is to set up this multifaceted program under Dr. Lee, under Dr. Leeper, where we're trying to make vascular surgery and vascular biology, vascular medicine as one component, but we can look at it behind the scenes of how we can understand what leads to this vascular diseases. And I promise you, throughout my presentation, I'm going to try to touch in all these different multifaceted. Of course, as I said, I'm a basic and translational scientist trying to figure out what goes wrong with the vascular plumbing. We're going to bring in stem cell biology. I'm going to touch on AI on one of the projects. We use tools such as bioengineering tools, how all of this could be linked to clinical research, and then having this really closed loop towards vascular surgery, the importance of having a basic and translational aspect to our surgical field. So what motivates my lab is this simple image illustration of the endothelium. Now, if you look at this endothelium, it is a monolayer of cells like a Teflon tape throughout this vascular plumbing, going all the way up from the brain to the toe, playing a very important role. Again, I'm a history buff, so I read a lot about medical history. The endothelium first was coined, the name itself was coined by Dr. Hayes, a brilliant scientist in Switzerland, who coined the term endothelium because the cells were lining inside the organs. And for almost about 100 years or 90 years or so, his concept of the endothelium was rejected because people kept saying that it's the same as epithelial cells. And his work was trying to show that these are the cells which are within the crevices inside the organs. And not until the 1950s, that's when, with the technology of electron microscopy came about, that we started to come to know that the endothelium is for real. And his work from 1865 to 1950s was rejected at multiple presentations. I mean, I would really recommend trying to read about the historical concept of how scientists and physicians have to go against the flow to prove something. And in the 1950s, many investigators from 1950s onwards have been able to understand what is the endothelium, how the name came, what are the different functions come about. And what they found is that this 7,000 square kilometers of cells across the mileage in the body, weighing almost about a kilo, has so many implications of vascular health and overall organ health. And you could clearly see that this one single Teflon tape-like layer of endothelial cells is controlling many different layers of smooth muscle cells and connective tissue in the vasculature, controlling its relaxation. So if I ask you, go ahead, take a run around the block, what will happen is that your endothelium is going to sense that you are doing some physical activity, release many of the different gases and hormones, causing the smooth muscle cells to relax so that more blood can be pumped into your skeletal muscles, allowing you to run. But at the same time, if you're going to go out into the cold, this endothelial cell is going to cause the constriction of the vessel in the extremities because we don't want to spend too much blood. So this small Teflon tape of endothelial cells controls a lot of the bodily functions as I speak, as you guys listen. But as I said, since 1950 all the way till now, we have figured out that the endothelium, the small layer, monolayer of cells, has many functions, not just as a barrier, which was initially discovered as the inner lining of the vasculature, but playing an important role in homeostasis, playing an important role in angiokyne secretion, development of the heart and the different organs, to inflammatory response, and most recently, knowing that the cytokine storm seen in COVID was being initiated by the endothelial cells within the body, being it in the lungs or being in the vasculature. We do have a project on COVID, but maybe for another day, how the endothelial cells respond to the virus in a petri dish. So now, since I've set you up, guys, with what the endothelium is about, giving a little bit of a historical concept, my lab works on endothelial regeneration. And this is where I said you're as healthy as your endothelium, because we really mean it. My goal is to find conceptual ideas that how we can improve the endothelial health, which can help us understand endothelial phenotype, which we see it in many different diseases. Atherosclerosis we know about. Now we're trying to find what is the role of the endothelium in AAA, aortic aneurysm. As I said, this is what one layer inside the vasculature, which is controlling the effects on smooth muscle cells, releasing stuff into the blood, but also to understand the role of the endothelium in cardiac disease. Now, my appointment is through the Division of Vascular Surgery, but I am also a faculty in the Cardiovascular Institute, and I felt this was a perfect amalgam of the vasculature and the heart, and trying to figure out what is the role of the endothelium in the heart. I mean, if heart is the kitchen sink, the vasculature is the plumbing, and it makes all sense to understand the pump, the heart, through the lens of the vasculature, the endothelium. So with that said, we need a really good tool to understand vascular diseases. Of course, we get a lot of primary tissues. Within our division, we have an abundant supply of vascular tissues, which are patient-specific. However, there is always a shortage to understand, especially if you're trying to understand endothelium or smooth muscle cells or vasculature. In addition, we need better tools to understand. And what better could it be that if we could have an unlimited supply of cells? Let's say we have an unlimited supply of endothelial cells, because it will give us this ample time and opportunity to study endotheliopathies in a dish. And that was solved by this Nobel Prize winning work done by Dr. Shinya Yamanaka, which came up with the discovery of the Yamanaka factors, which I think everybody in the room or in the virtual platform knows what he did. He basically turned back the clock, where he was able to take adult human totally differentiated cells, such as fibroblasts, and by overexpressing these 4 factors, which were known as the Yamanaka factors, he was able to turn back the clock and make something called as the induced pluripotent stem cells. Now, the name itself comes as iPSCs because these are induced. They are from an adult differentiated cells moving back to pluripotent stem cells. But the cool part about these iPSCs is that they can be differentiated into any cell type. And the adage goes, which we have added is if you give me a jar of blood, I can give you a pound of flesh. Literally, if you can give 10 cc of blood to my lab, we can make your iPSCs and differentiate them into whatever cell type which is needed. Of course, our interest is vascular cells, cardiovascular cells, and that's what we go ahead and we do it in our lab. We take this 10 cc of blood, which is patient-specific, your own blood, which can then be converted into endothelial cells and cardiovascular cells. And what I will try to show you here, it's a lot of fun. As scientists, we have many bad days, but it's usually a good if you can go and see within the lab these beating cardiac cells, which are derived from a patient who had a heart disease or a vascular disease. It really makes your day that it works. iPSCs are always there to be relied upon. They can be differentiated. So now we have a tool where we can take the patient, collected blood, take it into the lab, and then we can tell the patient, go back home, because now we're going to try to understand what cardiovascular disease could be, what could be the reason behind this thing. So as I said, the thesis of my lab is to study the endothelium and try to understand what is the role of the endothelium in vascular disease and overall cardiovascular disease, because we are in the business of not only understanding vasculature, the endothelium, but also the heart. And this is basically 60,000 feet, not 30, but 60,000 feet looking down what my lab works on. We are endothelial-centric lab. We work on the endothelium by leveraging this great tool of iPSCs. We look at the endothelium, but we look into the heart. Here you could see, we look at what is the role of the endothelium in heart disease, such as cardiomyopathies, could be inherited because of a mutation, which I'll talk a little bit about, but how we try to tackle heart disease, which usually considered as a cardiomyocyte, a heart disease, where the endothelium plays. We look at chemotherapy-induced cardiotoxicity. I mean, we can have a very healthy patient who unfortunately had got cancer, but because of the chemotherapy ends up with cardiotoxicity. But what is the role of the vasculature? If you think chemotherapy mostly is given through the venous system, ends up into the vasculature, remains in the vasculature, for sure it has many impact onto the endothelium and the vasculature. Of course, vasculopathy, this is the major chunk of it. This is why I am in the division. We are trying to study PAD, AAA, aortic aneurysm, and we're trying to make a whole biobank, which I'm going to talk about. But also, we try to study non-disease mechanisms, especially aging. And I'm going to try to present a little bit about what these tools of iPSCs could be to understand vascular aging. As I said, as we age, we have vascular aging happening, leading to many of these remodeling effects on the vasculature as well as the heart. And the cool part about the endothelium is that it is a great organ to chat. It chats with every other cell type. It talks to the circulatory blood which is flowing through, but it talks to the smooth muscle cells. It can talk to the heart, the neurons, the brain, and it's really good in passing information, but also collecting information to bring about changes. And I'm just going to show you the slide that how the endothelium is cross-talking to the cardiomyocyte per se, but we have many examples of the neurons being in the smooth muscle cells, being talking to the endothelial cells, and how during all the way from development to disease, how the endothelium plays an important role in bringing about these cardiac and vascular changes. So I'm going to show you two topics. As I said, the theme of the lab is to understand disease mechanisms through the lens of the endothelium, which is a crucial component of the vasculature. I'm going to try to talk about two main topics. One, looking at heart disease through the lens of the endothelium, and aging through the lens of the endothelium. And these two, this amount of work which we did in the last 2 or 3 years, I'm going to present today. So, give you a little background about cardiomyopathies. I'm pretty sure you know about it. Cardiomyopathies are inherited, or it could be environmental. We bring about those because of our dietary habits or lack of exercise. But one of the most common cardiomyopathies is because of a mutation. And these are inherited cardiomyopathy passed on from one generation to the other generation. Literally, you cannot do anything about the 100% penetrant. Usually, the answer by the time they hit 50 or 60 is heart transplant. And there's no way around it, knowing that if the patient has this mutation, they will pass on to the next generation and will suffer from heart failure, needing a new heart. And I focused on a specific kind of dilated cardiomyopathy, again, looking through the lens of the endothelium, which is called as cardiolaminopathy. It is a mutation in the lamin gene, which is a very, very important gene. It is basically the gateway between the nucleus and the cytoplasm, passing information, allowing chromatin changes to take place irreversibly, where your cell will lose its phenotype and become another cell type. So these pink strands right here are the lamin genes, which are, as I said, the gateway between those two cell types. And if you have a small missense or a nonsense mutation happening within this, it could lead to many of these diseases. as I said, dilated cardiomyopathy, progeria, which is an aging disease where these individuals who are 15 years old have a clinical phenotype and actually a physical appearance of an 80-year-old, to muscular dystrophy. So we picked this disease because it has wide implications within the cardiovascular system. But again, we are going to try to look through the vasculature because as cardiologists, we are too myopic looking into the cardiomyocytes and ignoring that the heart has more of the endothelial cells and the fibroblasts compared to the cardiomyocytes. So trying to show you into this, due to the shortage of time, I'm going to go really quick onto this project because it took about 5 years to start from where we recruited these patients to coming back to the patient itself. And I said before, I promise I'm going to touch on all the different facets of what we are trying to build within the division. So here you could see we're trying to combine basic as well as clinical science. What we did is we started recruiting these patients within our cardiology clinic who has this lamin mutation. And it's one of the most common mutational inherited cardiomyopathies, so it was easy to find. The goal was to see if we can find a 4 or 5 generational family within the Bay Area, because that would allow us to kind of look at one specific family, looking at how the gene dosage occurs between different generations. So we started asking these questions. First, let's go ahead and recruit these patients. So we got a 4-generational family with the same mutation passed on all the way to the 4th generation, to having an 80-year-old patient who underwent heart transplant, to a 16-year-old patient who had the mutation but no clinical implications, as healthy as it could be, but still having the mutation because they have been screened by whole genome sequencing. So the idea was to first recruit the patients and then use the tool which we have of these stem cell iPSCs with the Stanford Cardio-Vascular Biobank, which is one of the world's biggest iPSC biobank within Stanford, led by Dr. Joe Wu, who was my former mentor. And what we did is we made these iPSCs from these generational family, but we were able to differentiate them to endothelial cells. As I said, one of the cool things about iPSCs is you can differentiate them to endothelial cells and then characterize these cells in a dish. Now, as I said, once we collect the blood and generate the stem cells from these patients, we can tell them to go home because we do not need them to come into our lab because we have their cells, their DNA in the dish. We can differentiate them to endothelial cells, this beautiful monolayer which can happen in a dish, but we can also understand the different mechanisms which can lead to this endothelial dysfunction. And then, of course, once we identify a target, the idea was to find a drug, find a target. And if we can find a drug, maybe we can turn it back to the same patient population which we recruited to see if that is able to improve its vascular health. And that's what I'm going to try to show you in literally 5 minutes, 5 years of my work in 5 minutes. So here are the patients. We have this 4-generational family, which I just talked about. We recruited these individuals. We got 2 of the siblings which did not have the mutation, just to make sure that it's all within the family. But the first goal was to measure, do they really have endothelial dysfunction? And Dr. Lipa here has that machine in the lab, which you can measure the endothelial health, known as EndoPAT. And what it does is that it basically measures the reactive hyperemia index, comparing one arm to the other arm. It's really cool tool to study clinical endothelial dysfunction. And clearly you can see the one with the mutation has endothelial dysfunction. Now, so far, these patients have only been tested for heart dysfunction. Their echo, their stress tests, and people have not mentioned about endothelial or vascular dysfunction. Now, hypertension is not reflective of just the vascular dysfunction. Endothelial dysfunction could be reflective of how their endothelium health is. So clearly we see that they have endothelial dysfunction, or what I spoke about, that we were able to get stem cells, we differentiated them into this cobblestone-like endothelial cells, but went ahead and measured their function in a dish. Now, what are the major functions of the endothelium is forming angiogenesis, because it's important to form the vasculature in a dish, but also to produce nitric oxide. I mentioned briefly before that the endothelium secretes many cytokines, gas, which is nitric oxide, which has a big influence on the smooth muscle cells to cause vasorelaxation. We can do that in a dish. from the patient's own cells and measure its functionality of what it can uptake acetylated LDL. Now, clearly, you could see that all the disease patients who have the mutation have clinical endothelial dysfunction, but also molecular dysfunction, phenotypic dysfunction. But as I said, we really want to understand the mechanism in a dish so that we can have much more informed idea of what this disease mechanism is. Now, we ran many molecular assays. One is the RNA-seq. RNA-seq is basically looking at the 40,000 genes at the RNA level, because this is a mutational disease. The DNA having the mutation has an effect on the RNA. And as I said, lamin is a gene which causes chromatin changes. We looked at ATAC-seq, which is basically looking at the chromatin changes. And then when bioinformatically you integrate the RNA to the chromatin, you get our target. And what we were able to see is that KLF2 was downregulated in these patients. Now, you might ask, what is KLF2? KLF2 is an important transcription factor for your endothelial cells, which is important for mechanotransduction. And I'm going to really quickly skim through what mechanotransduction is. It is how your endothelium is responding to the flow of blood in your vasculature. You have turbulent flow, the endothelium is going to react differently. You have a linear flow of the blood, your endothelium is going to react differently. We really want linear flow and not turbulent flow. We see turbulent flow in atherosclerosis. We see in clot formation, which is having negative impact on this thing. So once we know KLF2, the next part of the puzzle was to find a drug which can increase KLF2 expression. A good old statin can actually increase KLF2. We looked at all the different families of statin and found actually the old lovastatin had a big impact on KLF2. Now, mind you, statin not only reduces cholesterol, but also increasing KLF2. That means these patients who have downregulated KLF2 can be upregulated by giving lovastatin. We do that in a dish, reverse the phenotype, reverse the function, but we followed these patients of N of 1 clinical trial, right? That's what I was talking about. We want to make an impact back into the patient, and we got these 2 patients, followed them up with lovastatin for 6 months and 18 months, and now you can see an improvement in its endothelial function, the reactive hyperemia index, which was impaired 18 months before of not receiving lovastatin. Now, you might ask me, can we reverse the cardiac dysfunction, which these guys have already set in? The answer is probably no, because you have already got a phenotypic change into the cell. Now, the question is, what about that 16-year-old kid who has the mutation? If we can give the lovastatin, convince him, I mean, it was hard to convince him because he did not have any clinical symptoms, he refused to take. But if we are able to, maybe there is a chance we might be able to prolong the cardiac dysfunction which is going to come in, or never know, I might not even have need for a heart transplantation. So we published this paper in Science Translational Medicine, and the idea was to fix the leak. If we can fix the plumbing. We published this in 2020, and because of the pandemic, I was doing a lot of these presentations talking about fixing the leak. My 8-year-old daughter goes to my wife and says, is my dad a plumber at Stanford rather than a faculty? Because we talked a lot about fixing the leak. But you know, the idea is we want to take this beyond. It's a crosstalk study. We want to take this from a 2-dimensional, which I showed you as a monolith, to a 3-dimensional, because the endothelium is really a 3-dimensional crosstalk organ. And what we said, okay, we're going to make something called as engineered heart tissue. I said I'm going to touch onto bioengineering. We have this new tools where we can actually make ex vivo engineered heart tissue or engineered vascular tissue from these iPSCs. Now, if we can make this vasculature ex vivo having the same DNA of the patient, it can give us so many cool different technologies looking for drugs where we do not need the vascular tissue from the surgeons. Of course, we might need it just for validation, but if we have these ex vivo tools where we can make these engineered tissue, we can look for many different drugs. We are not in a 3D, we are a 4-dimensional, because we need the blood flowing, because the mechanotransduction is needed. We have the devices where we can actually run the blood between these engineered heart tissue, making this more of a 4-dimensional platform in the lab. Now, really, we are expanding it where we can do ex vivo phenotyping of these many different diseases. We can go ahead and do single cell assay. These are the new cool technologies where we can take this engineered heart tissue from these many different patients and then go ahead and run single cell RNA sequencing, which actually allows us to study the crosstalk between the endothelium and the heart, the endothelium and the smooth muscle cell. And if we can understand that at the molecular level, then we can actually go back into the clinic and say, oh, it makes sense that the endothelium is secreting this cytokine, or it's not secreting the cytokine, having an effect on the smooth muscle cells or the cardiomyocyte. So the next 20 minutes, I really want to push on to the next study. Again, we talked about the endothelial health and the concept of cardiomyopathy. I haven't talked about chemotherapy. We have a really good a program within the lab where we're looking at chemotherapy-induced endotheliopathy, because it is quite rampant where chemotherapy is giving and have an endothelial function. But I thought maybe we can touch about aging, which is a non-disease mechanism where we all age, and actually goes with the adage is one is as old as the endothelium, because as we age, our endothelium becomes older and older. Now, aging is a much bigger phenomenon. I really don't take any loose ends saying that aging is just one different aspect. It is 9 different hallmarks within aging, telomere attrition to genomic instability to stem cell exhaustion. Aging is a complex phenomenon, but within that, one of the things which is inflammation. Now, in my previous slide, I showed that the endothelium has a big influence on inflammation. Now, can inflammation be added as one of the hallmarks for aging, because we go through sustained inflammation as we age because of our dietary habits, because of our lack of exercise? And just to give, there are 2 kinds of inflammation we all know about: acute inflammation, chronic inflammation. I'll take acute inflammation any day on chronic inflammation, because acute inflammation is something that I can see, I can cure. Chronic inflammation is something which is more sustained, has a big impact. And that's what we really wanted to figure out. Is there a connection between chronic inflammation, the vasculature, the endothelium, and aging? And if we can connect all these 4 different things, then maybe one of the hallmarks we could be added is inflammation, an important aspect of vascular inflammation. So it's not a novel concept. Inflammation has existed for many, many years. It's just that now we have much better tools and technologies to kind of tackle it. And this is the low-grade inflammation which I'm talking about. But what we started to think about, and this is work we started before I even joined as a postdoc within Stanford. This was done in Mark Davis' lab under the lead of Dr. David Furman. He is now at the Aging Institute at Buck. So a shout out to him that he got me involved in the study. It's a fascinating amount of work they had done before we even reached to it. The idea was that they're going to collect, it's a part of the 1000 Immunome Project, started way back in 1996. Way back, I was still in med school at the time, where what they were doing is they were collecting many responses from a lot of patients being recruited within Stanford, healthy individuals across a spectrum of 9 to 96 years old. And the idea was that if we collect enough information, now that being a blood sample, a questionnaire, the clinical information, we might be able to run many different tools such as transcriptomics, proteomics, functional phenomics, and then try to crunch the number using the machine learning platform to see if we can come up with a defined cytokine which might be responsible for this chronic inflammation. And if we put them on the spectrum of 9 to 96 years old, can we map that where systemic inflammation, cardiovascular health, and aging can come together? Now, we cannot do that on a regular basis. We need machine learning, or we need the computer to do it, basically. Applied statistics is the word. So here is their platform. They were trying to recruit many of these patients. Their clinical characterization was put into the neural networks machine learning platform. It was really developed by Facebook, which keep us hooked onto Instagram nonstop. they were really using that platform to put this data in. Deep immune profiling data was put in through it, and then the complete cardiovascular assessment being put into this neural networks to see what do we get out of it. And do not ask me what the code is, because I have no idea. I'm a physiologist who's trying to understand, believing what the computational biologist is saying. And this is what the figure we got out of this machine learning algorithm, where we were able to map the calendar age. Remember, 9 to 96-year-old, thousands of individuals have been recruited in Stanford. And when they put in all the data from their cardiovascular assessment, the phenomics, the genomics, they were able to come up with a linear pattern of looking at calendar age and something which we called it I age, or which is inflammatory age. And of course, we found a very linear correlation with many outliers. That means you could be a young individual, but you have a high inflammatory score, having a higher I8. So it doesn't mean that you are young. You might be young at heart, but you have a much inflammatory age. Or you could be an 80-year-old as a calendar age, but you have an absolutely low inflammatory age. So you can go ahead and eat the bacon as much as you want. And it was pretty cool, because now we have this machine learning-driven algorithm telling us this thing. Let's go ahead and try to validate that in a dish. That is it for real? Are there vascular cells? We're looking at vascular aging, because you see the higher the age we get, the more number of disease we get, and overall get a little more vascular and cardiovascular. We're looking for cardiovascular assessment to it. Now, by the way, if you guys are interested in knowing inflammatory age, we do have the platform to do it. We have these panels of cytokines which we can run. So what we did is we have all of these patients, the 1,000 immunome project, we have the blood samples. We ran through established panels of cytokines, found that one of them, the first one, the top, again, this is machine learning, so CXCL9, which is a cytokine secreted by the endothelial cells, to be the most top regulated, in addition to a few others which are present more in the older individuals. So CXCL9 has been correlated to endothelial dysfunction, arterial stiffness, but also in older individuals. So the goal was that, can we see the same thing in the dish? So we recruited those patients, we derived the iPSC, the stem cells, differentiated them to endothelial cells, and now you can see again that not only the endothelial progenitor cells, but also the iPSC ECs has an increase in CXCL9 expression. So now, from the clinical data, I have been able to validate that in a dish, that these endothelial cells from these individuals, the older individuals with cardiac dysfunction, have a high expression of CXCL9, honing onto CXCL9 as the important component to it. Now, again, as I showed you before, we can run many different kind of sequencing platform. RNA-seq is one of them. We could run RNA-seq to see why there is arterial stiffness and cardiac dysfunction in these patients. We see many of these targets. First, of course, we see an increase in the inflammatory response in these endothelial cells, because this is chronic inflammation. So now we are able to say chronic inflammation is responsible for arterial stiffening in older individuals because of CXCL9 being secreted at a much higher pace. I'm trying to go quicker on this thing, but again, when we submitted this paper to Nature Aging, of course, they want to see it in a model. Not only we have shown in human model, stem cell model, they wanted to see it in a mouse model where we see a similar phenotype. So what we did is we started aging mice. I mean, a 2.5 or 2-year-old mouse is something which is reflective of an 80-year-old individual. And then we went ahead and measured the arterial stiffness, the endothelial function by using a biomyograph. You can clearly see the older mice had more vascular dysfunction and had higher secretion of CXCL9. I'm going to go quickly. We published this paper in 2021. Now, the question is, can we reverse vascular aging? The answer is no. I don't think we can reverse vascular aging. But we got a little bit of media coverage for this paper, because a lot of billionaires who are older were interested in reverse aging. And we said that's something that we cannot do. What we can do is that maybe try to lead a happier, healthier life, change your lifestyle, because that can have a big impact on your endothelium, which can improve vascular health. I have a small lab within the Division of Vascular Surgery in the Cardiovascular Institute, but we have a big heart. And you're welcome to come visit the lab. We're located in the BMI building on the 3rd floor. Anytime you want to look at beating cardiomyocytes or endothelial cells, you're welcome to. Of course, I want to thank my mentors and co-mentors, Dr. Wu, members of his lab, Dr. Leeper, which I have the pleasure to know for the last 10 years. He's mentoring me on the vascular part, Dr. Phil Sau, many collaborators within the division, Dr. Lee, Dr. Dalman, some I've known for almost a decade, started with the T32 on Dr. Dalman. Now I have my postdoc, Anna, who's our T32 on the same T32, gives a lot of pleasure. So I started my career on the T32, and having a postdoc in the lab on the same T32 is an immense satisfaction, making a full circle. With that, I'll be happy to take any questions.